Well, hello everyone, and welcome to the fifth and final webinar of this webinar series. Today we will be talking about attachment and complex trauma. I am Dr. Kate Barlow, the CDC's Massachusetts Act Early Ambassador for the Learn the Signs Act Early program. A quick thank you to the Massachusetts Act Early team and to the CDC and AUCD for funding this grant series. Few housekeeping items. If you could please remain on mute because this webinar is being recorded. Please put all of your questions into the chat box. If I don't get to your question, I apologize. I will stay on after the Zoom to answer all questions, and you can also email me at any time. My email is kate.barlow@aic.edu. After today's webinar, you will be receiving a post-survey email. Once you complete that post-survey email, you will be emailed a copy of the PowerPoint slides from today, along with your certificate of attendance. We have been tracking all of the participants, so if you attended all 5 webinars and completed all 5 post-surveys, you will be receiving 0.5 CEUs. So today's objective is that participants will be able to recognize attachment patterns in children and understand how early trauma impacts child development. So the first thing that we're going to do is take a quick poll. So let's go ahead and take a look at some of these results. So true or false, chronic social isolation is considered a key factor in the development of mental, emotional, and behavioral disorders in children with disabilities, as well as in the exacerbation of existing mental health problems. And the answer is true. About 60% of you in the audience know about childhood adverse experiences and the correlating negative health outcomes, which is great. And let's see, 25% of you feel very well versed in attachment and trauma, and 73% feel they need more education. So that is great, and hopefully you will receive that education today. Okay, so we are going to first start talking about, we're going to listen to Dr. Nadine Burke Harris.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates. and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across a lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
So I hope you enjoyed that TED Talk. I think that she really does an amazing job of really sort of summarizing the importance of what we're going to be talking about today, which is, the impact of poor attachment patterns for children and trauma. So what exactly is trauma and attachment? Well, attachment is a mutual psychological process that develops over time. And it's really about the emotional connection between the child and the caregiver. So let's talk about what a positive attachment cycle might look like. And so it starts here where the infant experiences the need for sensory comfort and stimulation. So let's say the infant has a soiled diaper. The infant is then going to express their needs, and in a healthy attachment cycle, the caregiver is going to respond to that need and meet that need, and then there's gratification and bonding between the infant and the caregiver. I, as the caregiver, feel really good about being able to help my baby, and we have this positive interaction. And then the next time that the infant experiences a sensory discomfort, they're going to again express their needs, and I'm going to come over and I am going to respond to that need. And this is this positive attachment cycle of a newborn that is repeated over time and really works on that bonding between infant and caregiver. An inadequate care cycle is one where, again, it starts the same. The infant experiences the sensory need for comfort and stimulation. The infant has, say, soiled their diaper, and the infant attempts to signal to the parent. But what happens here is that the caregiver is not able to meet that need. Either the need is ignored or the parent is not able to meet the need. And so now the infant signals with great distress, right? They're extremely stressed. And what happens is this sort of difficulty in the parent-child relationship, because the inability to meet the infant's needs is very stressful for the parent and very stressful for the child. And it has a negative impact on the ability for the child and the infant to bond. And so when this happens repeatedly, well, then there is like a break in the cycle. So if the parent is not able to meet the infant's needs enough time, what happens is that when the infant experiences sensory needs, instead of signaling, they go straight to distress. And so the circuit is really broken. And so when a parent doesn't meet the needs enough times, we have poor attachment, and the infant goes right to distress, and it builds this distress between the parent and the child. And this is what we would consider an unhealthy attachment. So we all work in the birth to 5 here, right? And so we want to be able to know what we want to be looking for when we're engaging with families. So one of the things that we can look for is the parent-child interactions. Does the parent respond to the cues from the infant, and does the infant respond to cues from the caregiver? And are these responses consistent, and are they appropriate? And who initiates? Is it always the child? Is it always the parent? And how are they interacting? Is the parent always singing to the child? Are they touching the child? Are they talking to the child? So really, what sensory modalities are they using to try to interact? We also want to be able to observe how the infant responds to the caregiver. And so here are some terms that we'll often use. So for infant engagement, the infant might be alerting, they might have brow raising, head raising, facial gazing, mutual gaze. We really love to see an infant before 1 year of age, and the caregiver really with their heads, less than 12 inches apart, really looking at each other into the eyes and really maintaining that mutual gaze. Some disengagement cues from an infant might be facial grimacing, gaze aversion, crying, spitting, or pulling away. So if you're doing some observations and you see some of these cues, you really want to take note. And so Ainsworth has described 4 different attachment patterns that develop from children. And we are going to take a look at each of those different patterns. So the first one would be a secure attachment. And what would that look like? So as a child with secure attachment is able to separate from a parent. And as an adult, they will have trusting, lasting relationships. As a child, they may seek comfort from parents when they're frightened. And as adults, they tend to have good self-esteem. As children, when their parents return, they meet them with a positive emotion. And as adults, they will be comfortable sharing feelings with friends and partners. And as children, they prefer their parents to strangers. And as adults, they seek out social support. So for each of these attachment patterns, I have a statement below that's like as if that person was talking, right? So someone with secure attachment might feel, I am worthy. I am able to communicate my feelings. The next pattern is insecure-avoidant. So as children, they may avoid their parents, and as adults, they may have problems with intimacy. As children, they do not seek much comfort or contact from their parents, and as adults, they may invest little emotion in social and romantic relationships. As children, they may show little or no preference between a parent and stranger, and as adults, they may be unwilling or unable to share their thoughts and feelings with others. So a statement from a person who has an insecure-avoidant attachment pattern might be, I haven't gotten what I need, so I don't need anything from anyone. Characteristics of the insecure-ambivalent attachment pattern would be, as children, they may be wary of strangers, and as adults, they may be reluctant to become close to others. As children, they may become greatly distressed when a parent leaves, and as adults, they may worry that their partner does not love them. As children, they do not appear to be comforted by the return of a parent. And as adults, they may get extremely upset when a relationship ends. So a statement from someone with an insecure ambivalent attachment might be, my parents weren't always there for me. I don't know if my friends are really going to be there for me. So the last is the characteristics of insecure-disorganized. And for those of you who work with a lot of foster children, I really just want to mention that 75% of foster kids exhibit this insecure-disorganized pattern. It's also common with children who have been adopted. So at age 1, they may show a mixture of avoidant and resistant behaviors. And at age 6, they may take on a parental role. And at age 1, they may seem dazed, confused, or apprehensive. And at age 6, some children act as a caregiver towards the parents. So a statement from an adult with an insecure disorganized attachment pattern might be, I can't recognize my emotions. I can't think clearly under stress. I don't get a lot from relationships. So what might that look like? So someone who has difficulty with attachment and bonding is going to result usually in some type of relational issues. And some of those, this is not an all-inclusive list, but some of those relational issues might be depression. A person might be highly emotionally reactive. They may hold on to grievances. Trauma-based emotions can be hard to tolerate: anger, fear, hopelessness. In cases where there's been sexual abuse, sexual arousal can be difficult. Emotions expressed in interpersonal relationships can be extremely painful, especially if they're related to a trauma experience. The person may have self-injurious behaviors. They may have extreme behaviors that are often protective, or they have very large defense mechanisms. They may be hypersensitive. They may appear guarded and anxious. They may be hypervigilant. They may be difficult to redirect. They may often reject support, and they may make the same mistakes repeatedly. So next we're going to talk about, we're going to listen to this video that talks about the developing brain in children and what that might look like in a learning environment.
Hey, welcome back. Today, I really wanted to think about what's the best way to teach teachers about trauma without getting them distracted with all the technical stuff, and what's the most important thing for them to understand and learn. And I thought that the best way to do it might be to just make a difference between a learning brain versus a brain in survival mode. And so we'll just call it learning brain versus survival brain. And this is the difference. So learning brain is this brain that's open to learning new information, and it's completely okay with ambiguity and grays and vagueness. And it sees the big picture. It like pulls back and is on the balcony, can look over the forest and figure out what's going on. On an emotional level, people in learning brain feel calm, peaceful, maybe a little excited about what they're about to learn, maybe a little playful and having fun too, and definitely curious. And they're not afraid of making mistakes because it's just part of the learning process. And so they're not really thinking about themselves. And they actually feel a little bit of confidence that if they just apply themselves, they might pick up what they're trying to learn. Now, survival brain, on the other hand, is completely different. It's hyper-focused on threat. It doesn't like ambiguity. It wants clear, hard facts. It thinks in black and white terms. It doesn't want anything to be gray at all. And then emotionally, you can imagine that survival brain makes people feel panicky, feel like a little obsessive and afraid of getting things wrong. And they don't feel calm and open to learning new things. They just want to get things over with. And people in survival brain also really don't like making mistakes, and they are afraid of looking stupid too. So students in survival brain don't want to be picked on. They don't want to raise their hand and ask questions and look stupid. And so these people are also filled with doubt about their own ability to learn stuff, and they're afraid that other people can see how stupid they really are. Now, it's really important to understand how learning brain and survival brain interact, because survival brain always trumps learning brain. And it makes sense because survival brain is just trying to save your life. And so if it thinks that there's something dangerous happening, you better pay attention to it, right? But the tricky thing is that as survival brain stays on longer and longer, it's harder to get out of that. And it's harder to really go into learning brain. And the way I think about it is kind of like the myth of Sisyphus. You know that guy who has to push a rock up a hill, and then every day it falls back down and he has to do it over and over again? Well, being in learning brain is like being up on the high parts of that mountain. You can see the expanse of what's going on, but it also takes a lot of work to be up there. And at any second, if you're not paying attention and putting effort into it, it's so easy to slip back into survival brain again. And that rock that Sisyphus is trying to push up, well, that's kind of like stress. And the more stressed you feel, the heavier and bigger that rock gets, and it just pushes you back into survival brain quicker. Now, the kicker is that for traumatized people, stress is a really rigid and intense thing. And so with trauma, any little stress makes that rock grow way bigger than it normally would. And because people with trauma misperceive ambiguous situations as threatening and stressful, that rock just stays big all the time. Now, the good news is that the more you control stress, well, the easier it is to be in learning brain, right? Because that rock is a lot smaller. And what I really want to highlight for teachers is that the best way to keep students in learning brain goes back to why I spent so much time talking about attachment. Students best learn when they feel like they're safe and supported by the adults around them. So it's kind of like a baby elephant. You know how like on those nature shows, the baby elephant is like playing with leaves or exploring a tree or something like that and having a lot of fun. And the only reason why they can do that is because there's a whole group of mama elephants around that baby protecting it and looking out for danger. So a kid with trauma or who's stuck in survival brain, it's kind of like that baby elephant who doesn't have protective adults around them. They can't play and learn because they're way too focused looking out for threat and danger. So this is why I really believe that the most important thing that schools need to focus on, way more important than any kind of techniques or curricula, is really whether or not they are creating that environment where students feel like they're surrounded by these big mama elephants who are going to protect them and watch out for them and make them safe. And when students have that, I bet you it unlocks their curiosity, their eagerness to learn, and play as a way to learn. So I hope that's helpful. Let me know if you have any questions in the comments below.
So hopefully you benefited from that video. And so when we're talking about attachment and trauma, it's just important to realize that sometimes that trauma isn't necessarily one event that happens. It can be the fire that happens to the child or the horrific car accident, but it also can be a series of enduring conditions. So the parents continuously not being able to meet those child's needs, this is also considered trauma. And so if we think about other things that may be traumatic, like Dr. Burke said, you know, the parent with a mental illness or coming home and being afraid of violence within your home, these are also considered trauma. And so really, we want to think about trauma in a bigger context, to think it may be a one individual experience, but it also may be a set of experiences in which the child is just not able to cope, and the child is just overwhelmed by that experience, and the child feels like their life is being threatened, or that one of their caregivers' life is being threatened. So let's talk a little bit about the NICU, because all of you are working in birth to 5, and if 10 to 15% of children have had a NICU stay, then really, if you're a Head Start teacher and you have 20 children in your classroom, then that means that 2 to 4 children in your classroom, I feel you should assume, have experienced a trauma. And really starting to think about, wow, you know, we don't always get the past medical history on the children that we work with, but these are really important questions to ask the parents once we start building that relationship. You know, did your child meet your developmental milestones on time? And did the child come early? Oh, did you have a NICU stay? And really understanding that child's history will really help understand better what's going on with that child, because regardless of why the child was in the NICU, that child is at a huge increased risk for psychological, behavioral, cognitive, relational, and emotional deficits as a result of being in the NICU, right? So children that are in the NICU are often exposed to repeated stress or pain-related procedures, and they also don't have that typical bonding experience that they normally would with parents. So both of these factors combined, these infants are actually showing neurological differences in their brain scans. They have a decrease in white brain matter. And so neurologically, we know now what stress is really doing to these young developing brains. So with brain development, the right brain develops first, and the right brain is shaped by social and emotional experiences. And so when there's an early trauma, the brain is it's really blocked from developing in the way that we would want it to, and it really disrupts the ability for the child to emotionally connect with others and self-regulate. So therapy for a child who's experienced trauma often involves the integration of the right and left brain, really helping that child experience this fight or flight feeling and being able to get themselves out of it and be able to self-regulate and really be able to feel in control of their bodies. I put this slide in here because a lot of times in parents that I work with, as you all know, I'm an occupational therapist and I work in early intervention. And foster parents will say to me, well, the child experienced a trauma, but they were so young, they were 9 months or they were 18 months and they don't have that language. And that's correct. So a lot of times children will experience a trauma at a very, very young age. And those traumatic memories, they're not stored in the hippocampus like a typical memory. Instead, they're stored in the amygdala. So if we remember, Dr. Burke Harris was talking about how the amygdala is really responsible for that fight or flight response. So when a child is really young and experiences a trauma, they may not have any language associated with that trauma, but they may respond to stimuli and you really don't understand what's happening, but it's sort of like a remembrance of a traumatic event. So and one little boy that I worked with, the blue sirens, the parents feel it was around 9 months when the event happened and there was a lot of sirens going off. And so the sirens, when the child hears the sirens, it will really put him back into that traumatic state. So it could be smells, it could be sounds, but the child is remembering that traumatic event, even if they don't necessarily have words for it. So the amygdala helps you identify the threats in your environment. And if the amygdala is continuously activated, okay, then it has difficulty shutting itself off. And so all of a sudden, it's sort of the thermostat gets broken and the child is living in this heightened state. In brain scans of orphans from Romania, there was a dramatic enlargement of the amygdala. And one thing I wanted to talk about was if the amygdala is constantly sending off this fight or flight for these children who are living in the state of toxic stress, we know that when the brain is in this fight or flight, it really shuts off the ability for the brain to make the long and short-term memories. So for our children that are having this toxic stress syndrome sitting in the classrooms, how is this affecting their learning, right? And so Nadine Burke Harris talked about all of the children who are being sort of misdiagnosed with ADHD, but what about all the children who also have a diagnosis of learning disability? Is there a history of trauma there? We really want to open up the way that we're thinking about our children's behaviors that we're seeing. So when the child is experiencing this frequent fight or flight, this constant stress, as we said, this disruption of the feedback inhibition, this is when the stress, the body the thermostat gets broken and the body's not able to calm itself back down. So typically after 20 minutes, if you're in a fight or flight, you calm down and you go back to your normal state. This doesn't happen for children who are living in this continuous toxic stress. And this really results in stress-related disease and cognitive impairments. So the dysregulated stress response system has biological effects with organ problems, immune system problems, and cardiovascular problems. So what might that look like in the children that you work with? It could be the common cold, it could be tumors, it could be respiratory infections, it could be gastroenteritis, allergies, eczema, asthma, and even autoimmune diseases. So for those of you that work in WIC, this is another reason why breastfeeding is so important for the mothers, because the baby is getting these antibodies to help with their immune system right from the get-go. So we always want to encourage breastfeeding, but here's yet another reason why it's so wonderful. So just to review the ACE study, these 10 experiences on the slide are what Nadine Burke was talking about for the Adverse Childhood Experience study. In the original ACE study by Felitti, there was 17,000 people, right? The average age was 57, and 12% of the subjects had 4 or more categories of ACEs. I want to review this because in her study that she did, Dr. Burke Harris did 702 children, and the average age of the subjects was 8. And again, similar to the adults, 12% of the children in her study experienced an ACEs, 4 or more ACEs. And how that correlated with the children were that the children with 4 or more ACE scores were twice as likely to be overweight or obese. And here's the big one. Children with 4 or more ACEs were 32 times as likely to be diagnosed with a learning or behavioral problem. And that's one of the big takeaways from today. So what are some of the social effects of early trauma? Difficulty maintaining friendships, having oppositional behaviors towards parents and teachers, difficulty with trusting and affection. Children may lack empathy or remorse, and we often will see substance abuse in teens. So how do children respond to trauma? Well, most children underregulate, but children can underregulate or overregulate. So children who underregulate, they may have a lot of acting out behaviors and emotional tantrums. Children who are experiencing this, they have a lot of aggression, they have difficulty sleeping, they may have increased anxiety. Okay. And so when we're talking to families, and oftentimes we hear parents talk about how children are having difficulty sleeping. So we really want to investigate a little bit more of what might be going on. Because when children aren't sleeping, oftentimes, especially when they're little, that means that the parents aren't sleeping. And so we really want everyone to be getting a good night's sleep for good coping skills and for parent and child engagement. And then the children who overregulate, this is less often, but they may be very flat affected and they have difficulty reacting socially and emotionally. So interventions for children are really to help them with their self-regulation. And a lot of times the way that in which we do this is with sensory-based interventions. So just a quick note on hyperactivity, because I think it's important that we recognize that these children that are having this toxic stress have increased anxiety, and anxiety causes hyperactivity, and sensory hyperactivity also causes anxiety. And so here we have this circle, and the sensory hyperactivity and anxiety are both associated with abnormal amygdala activity. So self-regulation is the ability to attain, maintain, or change how alert we feel, which influences our ability to engage in tasks or situation we encounter each day. So we may very well might have to help children self-regulate. We may have to show them strategies of how they can be in control of their body. I'm now going to move over into talking a little bit about infant mental health. And this is Sherry Alderman. She is the CDC ambassador for Oregon.
Welcome to the Council of Early Childhood's Infant Mental Health Resource Toolkit. My name is Sherry Alderman. I am a developmental behavioral pediatrician and an executive committee member of the Council of Early Childhood within the American Academy of Pediatrics. To set the stage, I'd like to briefly describe to you what infant and early childhood mental health is. In medicine, the term itself can be confusing. First, in the infant mental health world, the term infant refers to infants and toddlers up to 3 years of age. And early childhood refers to children 3 to 5 years old. This is the time when early childhood brain development is so rapidly growing and sensitive to environment. Another important distinction is that the term mental health in the infant mental health world refers primarily to healthy brain development as opposed to diagnostic medical conditions. When thinking about infant, toddler, or young child mental health, I like to first recall the World Health Organization's definition of health. The World Health Organization defines health from a very holistic view, similar to the infant mental health fields. Health, in this case, is not just the absence of disease, but rather refers to the state of complete physical, mental, and social well-being. When we say infant and early childhood mental health, we mean the overall well-being of the infant, toddler, and young child. And as we know, the well-being of an infant, toddler, or young child must include healthy relationships with loving adults. And those adults, be they parents, caregivers, or early childhood professionals, need supports to be able to be emotionally available, sensitive, and responsive to the infant's or young child's needs to be the best parent or caregiver they aspire to be. An infant, toddler, or young child living and experiencing life through healthy relationships has the best chance for physical, mental, and social well-being. And when there is disruption or traumatic event in a young child's life, it is the healthy relationships with a caring adult that provide healing repair for that baby or young child. To summarize, Dr. Zena, a well-known and accomplished infant mental health professional, defines infant mental health as the young child's capacity to experience, regulate, and express emotions, form close and secure relationships, and explore the environment and learn, all within the context of the caregiving environment that includes family, community, and cultural expectations for young children. I hope that you find the Infant Early Childhood Resource Toolkit useful in your promotion of infant and early childhood mental health.
So she is promoting the American Academy of Pediatrics, their toolkit, which is not free to us who are not members, but I did put on the bottom of here and at the end the SAMHSA toolkit, which is free to all of us.
Thanks.
So in summary, in talking today, I would just want to make sure everyone is aware that we are all working in infant mental health. I feel like this term is growing in population and not everyone is really aware of it. But we are all working in the promotion of positive mental health and the promotion of positive bonding between the child and caregiver. And in Massachusetts, we have the Massachusetts Association for Infant Mental Health, and I'm going to talk a little bit about their endorsement program in a minute. Also in summary is that providing the emotional support to parents is really critical for child outcomes. And the more we can decrease parental stress, the more we can really help with that parent-child engagement. The other piece is that the child with one strong adult attachment can start to build resilience, and you might be that one person. So if you're the teacher in a Head Start classroom, you might be that child's one person, and you may be that connection that is helping to build resilience for that child. And lastly, some children just really do not have the ability to self-regulate, and they really may need the assistance of an adult. And so whether you're working on, the zones of regulation program or the alert program, you're really helping the child learn how to self-regulate and communicate with everyone in their environment. So the Massachusetts Infant Mental Health Endorsement Program is really a credential for all of us that work in birth to 5 that really states that we have the education and the cultural awareness to really work with parents and children on really building healthy relationships. This endorsement program is it's a series of education, and today's workshop goes towards that, as well as the beginning milestone workshop that we did that could also go towards your endorsement. But it's a really great program, and I encourage all of you to check it out. They have office hours. And one of the things that they wanted me to mention was that there is a cost associated with the endorsement, but there is a grant opportunity through the fees, the membership fees, to really help those who need a little financial assistance to complete the program. So even if you're interested, but you don't have it's not within the budget right now, go ahead and contact them and they'll be able to help you out. So here's the information to contact them. I've also provided a bunch of resources in this area. Why reinvent the wheel, right? So here is a great resource for social and emotional learning. A lot of these materials also come in Spanish, and there's a bunch of different training modules. Here is the SAMHSA Infant Mental Health Toolbox that I was talking about. There was also a really great webinar series released this year on infant mental health. And this is a series of 5 webinars that are all on YouTube. So if you're looking for more information, this is a great place to start. Here's also a bunch of resources for you. And again, this is our last webinar of the series, but please stay in touch. You can follow the CDC's Learn the Signs Act Early community on their Milestones Matter Facebook site. The Massachusetts Act Early team also has a Facebook page, and any future trainings will be posted on the Massachusetts Act Early website. Thank you all so much for staying and listening to me talk about attachment and trauma today. And thank you to the AUCD and CDC for funding. I'm going to stay on to answer any questions, and please reach out if you need anything. Thanks, everyone.